Hi guys, Scott Solar here with Viral Marketing. Welcome back to the Power Hangout with Nelson. Nelson, take it away. You're the man here. I want you to kind of lead this and introduce us to our guests and what we're going to be learning today.
Yeah, thanks, Scott. This is Nelson Vergel. Hi, guys. Director of PowerUSA.org. This is a series of Google Hangouts that we're doing once a month or so on different topics related to HIV health. Today we have probably the hottest and most important topic of all, the actual cure of HIV. There are 33 million of us out there. Obviously, we have to take medications every day to keep the virus suppressed. And the cure, even though people say there is no such a thing, I mean, there are conspiracy theories, we know that many researchers right now are trying to find a cure that is accessible to everybody in the world. We already know there's a cure patient. They call him the Berlin patient. We're going to talk about him. He's actually a friend of the three of us here in the panel. And we're going to get into details on what's happened after Timothy Brown was cured. Have researchers done anything to try to duplicate what happened to him and hopefully cure all of us? So it'll be a very interesting talk. It'll be around an hour to an hour and 15 minutes. We'll be transcribing it, and you can watch it after the Google Hangout is over on youtube.com. So I'm going to start by introducing our amazing speakers. I met these two men through my work as an activist. I'm part of the AIDS Treatment Activist Coalition. It's a coalition of activists that meet with academia and government and research and pharmaceutical companies to review and set the agenda from the community point of view when it comes to research in HIV. And Richard Jeffreys and Robert Reinhard have stood up through all the discussions on cure. These two men are committed. They love the science. They go to all the conferences. They read papers. Richard has a blog where he basically writes every month about what's happening with the cure. So I'm very honored to have my two peer advocates and activists on this Google Hangout. Richard Jeffries has been with the Treatment Action Group, TAG, for the past 14 years, where he now directs the Michael Palm Basic Science Vaccine and Cure Project. The project covers the pathogenesis and immunology of HIV infection and advocates for the development of immune-based therapies, effective vaccines, and a cure. Robert Reinhard serves as a community liaison and a steering committee member of the Can Cure Research Consortium in Canada. He's also a research associate and community team member in the Dr. Mario Ostrowski lab at the University of Toronto, where they're researching right now HIV cure or vaccine. Robert is a member of the IAS towards an HIV cure industry collaboration working group also. As you can tell, these two men have a great experience in following HIV cure research. And we're going to start by, I'll be asking questions. I'll be starting by asking them, especially starting with Richard, to tell us. I mean, most people are watching this Google Hangout have never even heard about the fact that there is actually a person that was cured with HIV. So Richard, start by describing what happened to him, or even before him, if we know of any other case, and then we'll go from there.
Sure thing, Nelson, and thanks for the invitation to participate today, and hello to everybody. I think there's been a little bit of confusion because there's two Berlin patients. One was reported back in 1998, I think it was, who was an individual who was treated very early after they'd acquired HIV infection with antiretroviral therapies, and then interrupted treatment a couple of times before permanently stopping, and he was able to control his viral load to less than 50 copies for many years. And so there was a lot of interest in that individual. He was probably actually the first example of what you now read about sometimes as called a post-treatment controller. He had certain immune response genes that enabled him to be able to control the virus for a long time without the need for ongoing antiretroviral therapy. But probably the more famous now Berlin patient is a more recent case, Timothy Ray Brown, who underwent a really very challenging series of treatments that he needed for cancer, for acute myelogenous leukemia, which is a serious cancer. He required stem cell transplants, which is when you receive stem cells from a donor. Your own sort of immune system is wiped out by a lot of pretty toxic immune suppressants, and after the transplant, you get a new immune system that grows from those new stem cells. What his transplant clinician, Gero Hütter in Berlin, did was find him a donor that had this mutation that prevents HIV from being able to gain entry into the immune cells. And so he got when his immune system came back from the stem cells, it was resistant to HIV. He's now been off therapy, I think, for just about 8 years.
Yeah, 8 years.
And virus has never come back. And he's been off antiretroviral therapy all that time. So the original Berlin patient, there was a new update on him recently. He still clearly has virus in his system and seems to be controlling it with his immune response to some degree. Timothy Brown is different because the virus, it's all active virus is gone. There's maybe a couple of trace bits of genetic material they can detect, but otherwise he seems to be completely cured.
Yeah, he's HIV negative, right, Richard?
The antibody responses are slowly declining, yes.
And what is this about Berlin? Why do we have two people in Berlin? I hear Timothy is American, right? Why Berlin? What's so special about that city, anyways?
I think one thing that's really key to this case, actually, is although it's not specific to Berlin, it's just that the European healthcare system enabled the transplant doctor to go search for many, many different stem cell donors to find one that had this unusual and quite rare genetic mutation that prevents HIV from being able to gain entry to the cells. It's actually a receptor called CCR5 that's on most of our cells, but a few people have a mutation, which means they don't have CCR5. IAVI uses it as a kind of latch to get into CD4 cells. He was able to search, I can't remember the exact number, it may have been 60, I don't know if you remember, Robert, 60 different potential donors that eventually found one. Okay.
It's 235 or so. We only got one, and that was even lucky too. The odds were
in the US, the insurance would never pay for that.
Yeah,
they would never pay to screen that many donors.
Yeah, and that you were saying, and I think we can connect the whole case before we jump into other patients that have received stem cell transplants and more fancy things like that. The post-treatment controllers. There's some people, well, they actually, as people may know, there's some people that can never get infected with HIV. Like 1% of the Northern European population has a genetic mutation that makes them basically, they can't get HIV. So it's a very small, it's 1%. But there's some other people, and it's very hard to predict, that they get infected with HIV, they get the diagnosis, and they start treatment. And then when they stop treatment for many reasons, either side effects or something else, their virus does not come back up. And as we know, we need medications to keep the virus from replicating. So we call them, or I don't know, we keep changing terms, Richard and Robert, you correct me. I haven't been to a meeting in a while. Post-treatment controllers, tell us a little bit about Robert too. If you want to add, maybe we can start with Robert on this thing about the Visconti cohort and these guys or girls, because I think they were females too, that were able to have an undetectable viral load for a while after stopping treatment.
Well, I will sort of throughout this talk ask, just as a general thing, for Richard to correct me if I'm wrong, because I think he's pretty sharp. But just generally, the notion of a post-treatment controller is much different than the sort of immunological circumstance and the experience of Timothy Brown. As I think Richard mentioned, when during the course of your natural infection, certain cells are responsive to antiretroviral therapy, and this is why people are able to go to their doctors on a regular basis and determine that they are what we call undetectable, a word that really just shows that we can't detect the virus using clinically available assays. But really, the virus is still hiding in reservoirs of the body where antiretroviral therapy cannot penetrate enough to attack the virus, where it's sort of sleeping and hiding. And that is the main barrier to an ultimate cure. But it turns out that even under circumstances of what we think of as normal antiretroviral therapy, that globally a few select patients have been identified in different circumstances, sometimes by accident, sometimes by design. They've been discovered where they've gone off antiretroviral therapy either voluntarily or in the course of some kind of monitored, specifically designed trial or observational study. And a few have been discovered to be able to control the virus either to what we still think of as very low levels and without antiretroviral therapy, or to experience different periods of remission or control of virus, but then are later found to have to need to go back onto antiretroviral therapy. So I think what, Nelson, you were calling before the Visconti cohort, they've sort of become the most famous examples of those. And the Visconti cohort is a group of people, depending on how you count, how many there are, based on the way the investigators have sort of followed this group. Sometimes they may go as low as 10 or maybe up to 20, but it's around that number. Are a group of patients who received antiretroviral therapy, people think, very, very soon after they first became infected. So, in other words, the opportunity for the virus to establish and make a foothold in the body, in the immune system, they think, was quite limited. And not only was the size of the reservoir likely very small or less than what people might experience during chronic infection, but the potency or the ability of their own immune system to be preserved at that point without deterioration probably contributes to their ability to fight the virus if they go off antiretroviral therapy. And
how long have we actually followed these patients?
So they've been followed for several years, and some of them seem to be able to control virus going out longer than 7 or 8 years.
But they're not cured, right? They still have viral replication.
No, they're not cured absolutely in the Timothy Brown sense. There's certainly virus still in their bodies, but they seem to be able to control it at a level that people seem to think of as clinically desirable endpoints, even when you are on therapy.
And do we know anything about these people? What makes them so special?
Well, there's the mystery, and I think Richard probably has a lot better clues about that, but I sort of alluded to a couple of possible answers of why that's true. One is it's possible that the size of their reservoir had already been controlled because they started early. Although that answer does not work for the vast number of other people that we also see who may have been treated early. There's something different about this cohort. So the size.
And when we say early, I'm sorry to interrupt. When we say early, how early is early?
They were given antiretroviral therapy at least within 10 weeks. People think of their becoming infected.
Okay, I'm sorry for.
Right. So yeah, that probably contributes to their ability to control the virus. And like I said, when you do control the virus at that early point, your own immune system, which was always fighting the virus when anybody ever gets infected, was not deteriorated as much as people who have late diagnosis and reduced CD4 counts. In other words, when you do become infected, you do start to engage in a battle with the virus, and you're partially successful, but eventually you lose that battle. So their immune system has been preserved.
Yeah.
And then a
Richard,
third option.
Richard, you want to add something else before we move on to another cohort? We have an hour, and we're going to cover all humans that have been tried in cure research, because this is really about what we have tried already in humans, not in monkeys, not in rats, or in humans, and what has worked and not worked. So Richard, anything else on the Visconti, and why do we call him Visconti anyways, Visconti cohort?
It's an acronym for something that I've now forgotten.
Oh, okay, so I thought it was a city in France or something, but it is a study acronym. Okay.
Yeah, virologic immunologic controller or something or other. I think it is. And no, I think Robert covered it. I mean, there is one sort of not so good bit of news about that particular cohort that just emerged recently and a bit accidentally, really. It was kind of buried at the end of a slide presentation from the recent International AIDS Society conference, which is that a couple of people in that cohort have quite significantly lost control of their viral load, sort of emphasizing that it's not necessarily a sort of permanent state, including one person I think has a viral load of over 100,000 copies, and another developed head and neck cancer, and so there's maybe a little, there's possibly a reason to be a little bit concerned that in some cases the sort of immune activity that's involved in controlling the virus may have some negative health consequences. But that's a difficult thing to know for sure because there's so few people in that situation. But it's an important thing, I think, for future studies to look at.
How about this this term elite controllers? Or they're not the same as the post-treatment controllers, right? Elite.
They're different in that they've typically never been on antiretroviral therapy, and they're just people that seem to have there's a very strong association with having particular genetics of your immune system and having really strong immune responses that target HIV. And again, there are some people, even though they control the virus very well and they're described as elite controllers, they can still very, very slowly over time, over decades, lose CD4 T cells and experience progression. So again, it's not a sort of perfect model, although there's maybe a subset of elite controllers who control their virus extremely well, who may be a better sort of model for something that looks more like a cure.
Yeah.
Good. And I want to make sure, I want to do a warning before we move on, because many people that are watching this Google Hangout have never really heard about this topic. I want to make sure people understand the guidelines right now for treating people with HIV are basically recommending that you get treatment as soon as you find out you have HIV, no matter what your CD4 T cells, excuse me, your immune system is. That has changed, okay? So I think some people that I've talked to have this fantasy that they may be elite controllers, so that they may be, their immune system will fight it off, and they delay treatment. I want to warn that this cohort, this small cohort, is a very small, like less than 3%, I think, of the population of HIV positives. And don't ever take that chance to assume that you're an elite controller and have this fantasy, because it is a fantasy, and seek treatment right away. As soon as you seek treatment, your viral load goes down, your CD4s go up, in most cases, obviously, and you stop being infectious to others when your viral load is undetectable. You know, that's something very important to know. And as these gentlemen are telling us, and they will tell us some more, it may, in the future, who knows, make a difference if you start treatment very early compared to later on, when the cure eventually comes up. We have no idea. I mean, we're going to talk about timeline, but it's definitely not going to be in the coming 10 years. There's a lot of work to be done. So I just want to make this clarification, because I don't want this message to be taken in a different way that can create some fantasies for some patients. So anyways, I'm sorry, Robert, I interrupted before you started talking.
Well, real quick, before we continue, I just want to mention everyone that's watching, in the upper right corner, there's some boxes. If you click in there, there's a question and answer application. You can ask questions throughout, and we'll try to get to them, or we'll get to them at the end. Real quick, before we move on, Nelson, I got a question just about something that Richard said earlier. With this Berlin patient, Timothy, if the doctors understood what type of cells that needed to replace these and there's certain people that they're able to get them from. I don't understand. I guess I'm ignorant to medicine in general, but why can't they look or replicate that type of cell to use that for some sort of cure?
Yeah, we're going to talk about this now. That's a good lead in to the work that Dr. Hutter, the German doctor, has been doing to replicate, and also work that some American doctors have been trying to do also with humans here to try to replicate in some manner. So I think Robert or Richard can take over on either Hutter's. I hate to mispronounce his name, but that's my Spanish accent, has done after Timothy Brown, to see if they can do it again in other patients. And maybe we can move on to the work done in the United States, especially in Boston. So either one of you.
Well, one comment maybe I'd like to make, going back to Timothy Brown as an individual person, you cannot say enough about what a sort of hero and model he really represents for activating the field of research about cure, and as an example both medically and personally in the way he has talked about it since then. And the starting point for Timothy Brown's story, as Richard mentioned, is that he only underwent this procedure because he had already a life-threatening cancer. People don't go through that procedure unless they do. So the question, the great question that Timothy Brown's case brought up for the field of cure research is, can we duplicate the result, and can we move forward to get the benefit in people who don't have cancer based on the circumstances that probably led to his cure? So not only the replacement of cells that might have this CCR5 mutation, which are probably a very large part of the reason he was cured, but probably not the only reason he was cured. But can we employ new techniques of gene therapy in the circumstance of people who don't have cancer to give them the advantage that we think was the reason for Timothy Brown's cure? And so on that score, yes, there are companies right now and clinical trials in the works, and also a big research collaboratory effort to try to engineer T cells from either from your own body or using your own hematopoietic stem cells, or generating the cells from your own CD4 reservoir, and take them out of your body, jigger and engineer them to give this CCR5 mutation, and then reinstall them back into your body to confer this protection. So again, the example of Timothy Brown under life-threatening circumstances is giving a research program in the context of people who don't have cancer and probably could benefit from that approach. So Richard, you probably have some good points to add, but maybe that's a little bit of the context.
Yeah, no, I think that's a really important context, and you know, somebody that you could maybe have on a future hangout, Nelson, who you know very well, is Matt Sharp, an activist who's actually participating in one of those gene therapy trials where they're modifying T cells to knock out the CCR5. I mean, he would have a lot of interesting information on that. And I think there's been some published reports about those trials and some little sort of bits of potentially encouraging data that perhaps some of those individuals are able to control their viral load a little better. I'd also echo what Robert said about Timothy Brown. You know, if you read any of the research papers that have been published about Timothy and look through the procedures that he underwent, it's really incredible just how altruistic he has been. I think he's had tissue taken from just about every part of his body to donate to science to try and help the research effort. So it's really incredible. I think maybe one other thing that's worth mentioning is just that you know, Robert talked about how it's being translated for people without cancers, but there are also efforts and some studies available for people with HIV who do have cancers that require stem cell transplants, that they will try and look for donors with this mutation to see if they can duplicate what happened to Timothy in other people. So there's research programs in the US for both adults and children and adolescents with HIV and cancer needing stem cell transplants. There's another one there's a Europe-wide one as well. And so there is a way of where people that need stem cell transplants can see if they can get a CCR negative transplants. The bad news is that there's 6 people that they've tried so far, and this kind of emphasizes just how complex and risky the procedure is. Unfortunately, all of them didn't survive, either because of the cancer being so serious, or because of what they call graft versus host disease, where their bodies kind of rejected the transplant.
Yeah, and Timothy Brown almost died 3 times too. So, and Richard, where can people find out about this? Where can people find out about these studies, or how to enroll? I mean, who knows? Somebody listening to this may be going through cancer and HIV, or lymphoma and HIV, or where do people find out besides maybe clinicaltrials.gov?
Sure. I mean, clinicaltrials.gov is the central sort of repository, and to sort of shamelessly plug the Treatment Action Group website, we do have a listing there that sort of basically just compiles what's available, or at least as much as we can find of what's available on clinicaltrials.gov.
And what's the name of the site?
It's treatmentactiongroup.org. And the link to the Cure Trials page is on the front page.
Thank you. Robert?
I guess I just want to add another little note about these ideas and these strategies. It does sound exciting, not only about the innovation and the possibility of this new kind of scientific research to imagine the possibilities, but when we start talking about these really major disruptions and replacement of your immune system and marshalling these different technologies to do it, we should be careful not to just say, oh, well, at least I don't have cancer, so maybe I should try this. It sounds emotionally appealing.
Yeah.
But every procedure, and especially these new gene therapy procedures, have risks of their own. And as we were alluding to before, we think we have a good idea of why Timothy Brown was cured, but we don't know absolutely exactly. And a lot of the studies that Richard was mentioning are really trying to be very sensitive to those important distinctions. And it's important to think of these early trials as really, again, very early stage explorations to try to find not only the answers but also the right questions. And
yeah, and let me ask you guys a question, a basic one, because I get it all the time. We're talking about stem cell manipulations, transfers, and what happened to, and as I said, this audience may never read about HIV. What happened to the vaccine? This is a virus. Can we why have we been so unsuccessful after millions of dollars in finding a vaccine for HIV? I know it's a very generic question, but probably most people watching this would have it. So you, Robert, or Richard, and you can both add, because it is an answer that requires some explanation.
Well, first I would say that we haven't been entirely unsuccessful. I think people know, probably from following the news, is that yeah, it's been a long time, but after 30 years, the first clue to a successful preventive vaccine was found in a large trial in Thailand, which goes under the name of RV144, where a limited amount of protection from HIV infection was discovered. And following up on that vaccine trial, there have been a number of attempts to find out, well, why did that trial have some limited amount of protection? How can we make it larger? How can we expand it to other people? So that's one thing to point out. But a big reason of why it's so difficult to find a vaccine is because the virus is found in many different forms throughout the world, and figuring out the traditional kinds of blocks, like whether antibodies are the reason or other kinds of immune responses are able to block HIV, have been very difficult. Now, having said that, another benefit of the vaccine trials and the Thailand trial is that people in cure research are starting to think that maybe some of the reasons that vaccines work, antibody or other responses, might be available for cure research as well. That was a short answer to a really hard topic that, again, Richard is a great expert on, but I just wanted to, again, sort of lay the context there.
Yeah, net terms. Richard, you want to take a swing at the very general question?
Sure. No, I mean, I totally agree with Robert. I think there is, there is some really distinct signs of progress, over the last decade. And I think also the burgeoning field of cure research has helped rekindle some interest in using vaccines therapeutically. There's ongoing trials now where they're attempting to induce immune responses in the hope that they might help clear the reservoir of HIV that persists despite antiretroviral therapy. It's very early days, and not really any signs of success yet, but that work is ongoing, and there's some hope there. Also, as they've got to understand antibody responses to the virus better, it's become clear that they can perhaps help target the cells containing HIV for elimination. So there's a lot of interest in using what they call broadly neutralizing antibodies in cure research. There's a bunch of trials already ongoing of several different of those antibodies, and interest in combining them, in fact plans to combine them with agents that might wake up the reservoir in people that are on antiretroviral therapy. So that although there's been a lot of money spent, it is paying off, and I think it's not just going to pay off in the prevention realm. It's also paying off in the therapeutic research.
So, Richard, I was talking to you before, like today, and this is a very generic question too. And we're trying to not only make this a science-related hangout, but one that discusses other things that I get asked all the time. Like, there are many people out there that think that the cure is already available, and the pharmaceutical companies are basically not wanting the cure of HIV because they want us to be taking medications for the rest of our lives, and they really don't know, and that's why we're doing this Google Hangout, that there is a lot of research going on. What do you tell people when they say there's actually a cure and pharmaceuticals are just basically hiding it from the world?
I think, it's when you look at there's certain things in history, you can understand where the people can be very suspicious of what's going on, particularly of mainstream government institutions and so on. I think though the reality is, if you look at the example of hepatitis C, particularly recently, there's been a lot of development of therapies that are curative, essentially, of hepatitis C, that are effective and are getting safer. And the only thing, there is a definite profit motive there, and the bad side is that companies, they have no problem making these curative therapies. They just want to charge a really large sum of money for them.
$1,000 a day, like for hepatitis C.
Yeah. So I think, there isn't. It's not that they don't want to. If they could develop a cure for HIV, if there was one already, it would be out there. It would just cost a lot of money probably, and activists would be having to do the work they did with antiretroviral therapy to try and make sure that the price came down.
All right, let's switch to another topic of not cure but remission. In the media, maybe over a year, 2 years ago, we were hearing about the baby that got cured, in Mississippi, everybody was talking about the baby that got cured with HIV. Can you guys bring us up to speed on what's happened to that baby, what happened to the baby, and if any other babies have gone through the same experience after that baby, Mississippi baby, they call it, right?
I think Robert follows pediatric research very closely, so maybe I'll
Robert?
answer that.
Okay, so but just to clarify, so the Mississippi baby was an example of sort of what I mentioned earlier. It wasn't a pre-planned investigation. It was accidental, a finding that a family which was in very difficult circumstances presented to a clinic where the mother had not received the kind of prenatal care and care during pregnancy that we would like to see every mother have. And the child was found to be infected at birth, but sort of luckily for that child, the medical team that was investigating thought, well, we are able to determine this right away. We're going to put this child right away on a complete regimen of antiretroviral therapy and see if that is helpful for this child. So the family continued to provide antiretroviral therapy to the baby, but again, because of personal circumstances in the family, the child actually went off antiretroviral therapy, and when the family was able to re-enter the clinic setting, recognizing that antiretroviral therapy had not been given, it was found that the child seemed to be undetectable. Not only undetectable in the clinical sense that we mean normally, but they couldn't find virus no matter how hard they looked in this child. Now, that circumstance continued for a period of about 27 or 28 months. But then, after 28 months, without much warning, but maybe with a little bit of warning, the virus rebounded and resurfaced in that child. The child had to go back on antiretroviral therapy, and fortunately, that's been successful, and the child remains healthy and controlling the virus. So the Mississippi baby at first entered the news media as an example perhaps of the second person might have been cured, but it turns out they weren't. What's very interesting about that child, and we shouldn't necessarily call it a failure, the question is not why so much the virus rebounded, although that's important, but why did it take so long? Why was this child able to control the virus for 28 months? Because normally, when you go off antiretroviral therapy, even as a child, the rebound time is very short. So that has sparked a great effort to try to expand or to look at pediatric care and the possibility of remission strategies in children worldwide and in other countries. In a sense, infants and babies are almost the ideal subjects for testing the idea that if you give antiretroviral therapy right away upon diagnosis, you may be able to control the virus when they get off of therapy. Because we've got them right there. We know when they were infected right away. It's not a matter of somebody going to get tested later on. So in Canada, there has been an effort to try to find other examples of children that are given antiretroviral therapy immediately upon birth or within hours of birth. And 4 children at the moment are being followed. They are still taking their medication, but the assays that are used to find virus in these children still cannot detect virus. So it's hopeful that maybe they will be examples of this kind of post-treatment control.
But we hardly have any babies that get infected anymore, right? I mean, you want to make that distinction to the audience that, at least in the developed world,
That's right. We all should recognize that any child that is born today with HIV infection is to a very large degree a failure of the healthcare system, because we are quite able, with good prenatal care, with attention, especially during the period just before delivery, at delivery, and post-delivery, to make sure that every baby born to an HIV-infected mother is virus-free. And a great effort in global response is to make sure that we expand on that possibility. Nonetheless, despite best efforts, children will be infected. We're not there yet.
But it's usually when the mother is treated for their HIV and they're successfully treated, they cannot pass it on to their babies at birth, right? That's what we know.
Well, that's part of the way of preventing mother-to-child transmission, along with other things. A big circumstance to be concerned about for families is that even if you're successful at preventing infection, through the birth process, breastfeeding continues to be a period where it's possible to transmit virus.
That's true. That's true. Guys, we were talking about controlling the virus after treatment. Do you want to discuss that graph that we brought up before? Right now, I think it's a good time to bring it up, or you guys want to add anything before we do so? Yes, no? Scott?
Sure. No, I think it would be a good time. I just realized there's a couple of other cases that are sometimes said to be similar, somewhat similar to the Mississippi baby, which is these two adults in Boston who also, a bit like Timothy Brown, they had serious cancers that required them to undergo stem cell transplants, but they received stem cell transplants from normal donors, so they weren't HIV-resistant stem cells. They remained on antiretroviral therapy through these procedures, and what happened is that after the transplant had successfully sort of rebuilt their immune system and the cancer was in remission, when the doctors looked for their HIV reservoir, it couldn't be detected. So I think they are mentioned on these slides. Just there was two individuals.
Let's expand it if we can before we go on. Can you expand it a little, Scott? I think it's also hard to see the bottom because we are kind of covering the y-axis.
Let me see.
And just scoot it up a little, maybe, or I guess not, or maybe decrease. There you go. That would maybe the other way around. Make it smaller, I guess. I guess that was smaller. Hey guys, just technical issues that we go through in a live show. Well, we'll leave it as this. So I think that will do. Just small. Yeah, we'll leave it as this. We can make it work. Yeah, Richard, continue. I'm sorry.
So what they did when they realized that they weren't able to find virus, these two individuals, they were still on their antiretroviral therapy. They did a lot of sort of checking with their ethical review people at the hospital in Boston where these patients were being seen, and eventually got permission to interrupt the antiretroviral therapy. And sort of similar to what happened in the Mississippi child, there was no evidence of rebound for some period, and some of the initial news stories were suggesting that they might be additional examples of cures of HIV infection. Unfortunately, again, there was a viral load rebound somewhat quicker than in the child, one at 3 months, one at 8 months. But they didn't have any immune responses against the virus, and so it doesn't seem to have been that the virus was controlled. The thinking right now is just that they had such a small reservoir that it didn't wake up for quite some time. And so,
Richard, before we continue, I'm going to interrupt you here.
No, it's fine.
For everybody that is watching, so every line, ART means antiretroviral therapy, which is a combination of at least 3 drugs to treat HIV. And those lines, there are 2 green lines, 1 orange, 1 purple, 1 red. Those are actual people, right? Or cohorts, maybe we can say
Sure.
that. Not people, but they're groups of people. Some are one person, some. The red one is the only one that is flat throughout, and that's Timothy Brown. And then
Yeah.
the purple one is the Visconti trial, the people we talked about that control their virus at a low level after stopping treatment. And then the orange one that goes up later on, the viral goes up, is a Mississippi child, right, after 28 months. The green one, top of that, is a Boston, I guess one of the Boston patients, 8 months, what does it say? And the other Boston patient, their viral goes up after 3 months of stopping.
Yes.
And is that how it works? And the last one, I don't know, the light, the beige one, don't know which one that is. Anyways, so I just wanted to make it clear for people that are watching the Google Hangout. Go ahead,
Yeah,
Rich.
I think that beige one is what typically happens when somebody
okay.
when somebody stops
Right.
antiretroviral therapy, where it comes back within a few weeks.
So what we want is everybody to be in a flat line on 0, right? Because when you're cured, you have 0 viral particles. You may have, like you said, remnants of a virus like Timothy has, but they're not real viruses, right?
That seems to be the case. And I think the other important thing about the Boston patients and Mississippi child is that during that period when they were off antiretroviral therapy, and it wasn't just that the viral load was undetectable, all these other very sensitive measures that they have of HIV DNA, what they call the reservoir outgrowth, to see if they can find virus that can replicate. They couldn't find that anywhere. I think they even looked in different tissues of the Boston patients, and they couldn't find it. So it really seemed to be just sort of no viral activity for that period, and then unfortunately it started up again.
So would you say we're going through a rough period, or are we, I know Robert is very, his language is very optimistic. It says with no failures, we're learning. Obviously, we are learning through all of these cases, but at the same time, are we starting to lose hope, or are we getting into an area where, and everybody, I get people emailing me at thebody.com where I answer questions about the latest cure. We get, and everybody watching this Google Hangout, if you've been on Facebook or on TV or radio or whatever, we've heard about the latest researcher that found the cure. So people are getting either numb to the word cure, or they're getting cynical about the word cure. Is excitement starting to fade away after Timothy was cured? Anybody can answer that, Robert or Richard.
Well, I think I'd like to go back to a little thing about what Richard was just saying, that even with these very sensitive, very particular assays and sampling into tissue, where for the period of remission we couldn't find it, and then it comes back, it just shows you really how difficult a scientific question this area of study has become. So like any kind of very difficult and very important, you started out, Nelson, by reminding everybody that globally, the millions of people who have HIV are really living under a lot of different circumstances. So how can we turn these few examples, we're talking about people, 10, 20, 30 people compared to millions of people who have HIV. What are the clues that we're learning from this? And I think we are learning a lot of clues. But to me, when I read these newspaper accounts of another person, another cohort, what it reminds me of is not that these are necessarily going to be the examples of cure. It reminds me of how people should still be interested in research, and to me the interesting participation of humans right now is not so much clinical trials, although they are important. I'm sort of more interested in people getting interested in the idea of allowing sampling, more explorations of where the reservoir is, and not so much in the example of a clinical trial with an intervention, but to answer these questions. Why does it come back? Where is it hiding? There's a great need for people to be engaged in the questions of answering not only did they have cure remission, but why? Or what can we learn by exploring samples in their body? So that's an earlier stage, and I think there is hope if we continue to keep at it.
Richard?
Yeah, no, I think it's it can be difficult because the media is not great about writing about science generally, and it will always kind of go for the headline type of story. And I think when you read a lot about cure for HIV, it's a particularly potent thing because this has been a heavily stigmatized infection, and so there's a powerful desire, an understandable desire out there to get to a cure, and reading about it for years, you do sort of wonder exactly what's going on. I think one encouraging thing is that it has quite quickly become such a major focus of the research effort. I think there are some quite incredible people that have been instrumental in making that happen, including Francois Barsanussi, who was one of the discoverers of the virus. And so there's a real drive out there in the scientific community to get to the point where a cure is achieved. And so I think that is reason for some optimism. But at the same time, you have to be wary of the headlines that make it sound like there's going to be some quick fix, because science is challenging, it's complicated. There are incredible, and Robert knows much more than me about some of the very detailed practical issues that are involved in conducting research studies in companies, agreeing with each other that they're going to combine different therapies that might be important to combine in these studies. There's a lot of sort of stuff that has to be gone through, and some are, it's not just bureaucratic. It's about protecting people and making sure that in some sort of crazy rush to test something, someone gets killed or injured, which would be really terrible. So I think that there has to be a certain amount of caution, but at the same time, there are encouraging potential treatments, and I think maybe the broadly neutralizing antibodies that we mentioned earlier are sort of one example of something that does look very good, which is being studied right now. There's going to be results from those studies within the next few years. So there are some things that are nearer term that I think are worth looking forward to. I'm not saying they're going to be curative, but I think there's the potential for taking some steps forward in the near term.
So you were mentioning about companies or researchers trying to collaborate, because it seems to me, at least to me as an activist, and I go to meetings where you guys are ahead of the game when it comes to cure research. I mostly work with people that are infected or prevention. But anyways, who is funding this cure? I mean, do we have enough money to research the cure? A few years ago, maybe 3 years ago, I made a video that actually made the point that we didn't have enough cure for enough funding. Who's funding this studies?
Well, as usual, if you looked at a map of the source of the funding, the largest share comes from the United States, and maybe I should let Richard take this over, but there is an organization which is a collaborating effort between AVAC, TAG also contributes, and a number of people to sort of look every year at the level of funding for now pure research, but also for other research directions like vaccines and other prevention modalities. So a big boost to that level of funding came in the last couple of years from the NIH, which again, sort of under an almost presidentially directed initiative and an NIH strategy plan to elevate cure research as a priority effort among the different funding pools or pots of money. And each year that line of money keeps going up. Is it enough? Well, it's hard for people like us, I think, to judge exactly how many dollars are not only being spent, but are they being properly spent? Are they being well spent? I think there's a general sense that, sure, we need more money, but we're competing against a lot of other things that are also important, and I think we have a great trend that government sponsorship, foundation sponsorship, and private company sponsorship is sort of trending in the right direction. And when we have more successes, when we can get more initial findings that give direction, that's when people start piling on more money, when they see a chance of success.
But they're at least much more funding than we had just 3 years ago, and there's
Absolutely.
a lot more activity. There are, 4 or 5 conferences a year on cure stuff, so it's a very active. There is a competitive feeling, in my point of view, when I go to meetings about finding a cure. And what I'm finding out too is that we're going to get people we're going to have to make them work together, because the cure may actually be a combination approach. Maybe it's not going to be one thing. It's going to be a combination of maybe antibodies and stem cells and treatment and this flush agents that actually flush the virus out of it. So that's probably the hardest thing. People are studying different modalities by themselves, and I don't think we are yet in the combination phases, or maybe in the stem cell we combine it with treatment. But do you think that's a barrier? Well, probably one of the hardest barriers is to get people to combine their different approaches.
I think as a business matter, that's a very important consideration. I mean, it's hard to get people to sort of mix and match the combinations that are based purely on what makes the best biological sense, when people also have a competing interest to think about what is it that they can sort of control in terms of their operations. I mean, I don't want to sound too cynical, but we know from the preventive vaccine field that it takes a lot of work to get combinations that make biological sense to match or harmonize with combinations that are owned by different parties.
Yeah, and something else I want to add is that any research done in HIV cure research actually helps the world in all kinds of immune-based research for all different pathologies. So we're learning things working with HIV and immune-based stuff that can be applied to other diseases. And also we're learning from cancer, as we know in some studies. So anyways, we're getting real close to, basically, it is the time to close the Hangout. Richard, do you want to add anything? I want to find 2 things. How do people get involved? If they want to get involved, there are people like you. You guys are, working your asses off trying to be the best activists and go to meetings and advocate, to review the research and digest it for the patients, to make sure that patients that are enrolling in studies know about the risk they're taking and know that this is an altruistic thing that we're doing. Most of the studies are not going to benefit, or all studies right now are not going to benefit the patients. The patients enrolling in studies are basically doing it to help the world. So, and Richard and Robert and myself and others, I'm not, as I said, as much involved as I'd say are working hard, and they need help. So how do people get involved in HIV cure research activism? And B, how do they contact you? And C, where can they learn the basics? And let me, one more thing to add. And if there is, you guys work for nonprofits, do you guys actually take donations from people? So I have 4, and I'll remember them again if you guys forget. So let's start with, how do people get involved? Richard.
So I think that there's a few different groups. There's actually some talking about funding. The National Institutes of Health in the US funds these Martin Delaney collaboratories. There's going to be some new ones funded. There's community advisory boards for those collaboratories. If you go to the websites, if you look up Martin Delaney collaboratories, there's contacts there for people, and you can ask about getting involved. And particularly look out next year when there will be an announcement from the National Institutes of Health about newly funded collaboratories, and they'll say where they're located, and it will be possible to contact people if you're interested. I think also, that AMFAR is supporting a lot of research I think, in terms of donations, that money definitely goes to research projects, and they've funded quite a lot of innovative research there.
Good. The other questions, I guess, is anybody remember?
I'd like to add a little coda to what Richard said, and that is, again, going back to the way you started out, Nelson, really the distribution, the number of people who need a cure, who deserve a cure, is global. And we really need to find more ways to have community engagement, education, involvement, and participation where the epidemic is all over. And on that score, there's certainly an awful lot of work left to be done. It's great that a lot of activity has happened so far in the United States, but really the challenge is to, first of all, I'd just like to say having more educational opportunities like the one you're providing is a great thing to always keep doing. But really, we need to think about engagement where a cure is desperately needed everywhere, because everyone deserves it.
Thank you. Scott, you want to have any closing statements technically do we have any questions, or just move on and close? Well, I'm going to just plug the next one. Well, everybody, thank you for taking the time. It's a little over an hour, and it was a very dense material. We'll have a transcription of the material so you can actually read it. There are some words that may or may not have made any sense to you, but we'll try our best in the transcription to describe them to you. Our goal, as I said, is to bring everybody up to speed, and the fact that there are a lot that is being done to find a cure for HIV. There's no conspiracy theory, and remember to take your medications if you're HIV positive. The sooner the better. And we will have a Google Hangout every month. The next one, I'm looking into 2 different topics on aging and HIV. We're going to probably talk about cognitive function, the mind, and how I've been positive for 33 years, and we're getting older, and is a HIV virus affecting our brains, even though we have treatments? So anyways, stay tuned, and you can also, as I said, watch this video on YouTube. So thank you so much, and stay tuned and find out from our emails and Facebook postings for the next one in 30 days or so.